coming October next month, or next month from tomorrow, everybody will be going on about breast cancer month, breast cancer month. And once you work in the hospital, they will be asking you questions. Should I come and do my mammogram? So many questions will be asked, and that's why we thought we should empower the healthcare providers, now. Breast cancer, commonest cancer in females. This part of, well, the literature is, some people say more down south, but generally it is the most common malignancy in females. Some would argue that survive like this, but I think breast still tops. We talk about the staging or the diagnosis. How is breast cancer diagnosed? The ultimate diagnosis is when a patient comes and shows you the histology and says, they have breast cancer. But what is really significant about this, and how does it really affect? Because sometimes I meet patients and they in their head, I have breast cancer, is surgery, is chemical, is radiotherapy. Does this sequencing matter? Does it matter which you do first? Are there certain principles that guide the decisions the oncologist should make to push that patient towards a better chance of being cured or reducing their chances of having a recurrence? Once the patient has had breast cancer, they live with the fear of it coming back for life. Once you've had a loved one or you've experienced cancer, you spend the rest of your life afraid. So, every decision that should be taken from the diagnosis to the follow-up should be geared towards reducing the chances of the cancer coming back. It should be geared towards reducing the chances that if it does come back, it shouldn't come back as a systemic disease that now becomes incurable. It should be geared towards saving this patient's life, pushing their disease-free survival. We know it's a disease that we can't cure most times. But guess what? We always talk about the 1/3 that you can cure if you prevent, the 1/3 you can cure if you catch early. So I'm hoping that this group, this discussion we're going to have, is going to push us towards sequencing those decisions based on scientific guidelines. The epidemiology in the world, it's okay, but I want to talk about the epidemiology in national. In the last 1 year, we have seen 790 new patients with cancer. When I say new, because we have a new patients clinic, it's on Thursdays. New patients. Doesn't that figure just hit you?
Scary.
And out of that 790, 242 were breast cancer. That is 1/3? About 1/3 of that figure. It's a significant figure. Mind you, there are many, the ones who don't show up are those who came and wanted to go and they died before they were evaluated, they are not captured. Or those who came and when they just heard the price of radiotherapy, they ran away. So the figures are even more. Now, I said something, I said we need to know how to sequence their treatment. If you get it right, a patient who is stage 3, you can pull her back towards 1, instead of her tipping over into 4, which becomes incurable. Gone are the days when we just did, anybody. Now we're talking, everybody has their own, specialized treatment. So, when that patient shows up in the department, the first thing you're going to do, but there's so many things we're trying to do. We're trying to do a navigation, but I'll come back again to this same room and tell you about patient navigation and oncology. But today, the patient is already in the department, already has an appointment, is already in front of the doctor. I've just fast forwarded like 2 weeks, but let's just get there. The diagnosis has been made. The patient is in front of the doctor. The first thing is the workup. And the essential reason why we need a workup, and not just an ordinary workup, is standardized workup. And I'm happy that I've seen doctors from different parts of the hospital in the world. We need to standardize our workups, meaning that I'm not comparing chest X-ray with chest CT. It has to be the same thing we are all doing. On that slide, I essentially have all the things that, and when I get to the future slide, I think let me not waste much time here. So people don't start falling asleep, but the things that are relevant are, they must have a histology, which is a confirmation, and then an immunohistochemistry. You won't believe it, but today one of my colleagues is in MDCN because a patient who did not have immunohistochemistry was managed. She has turned around today now and is suing because guess what? She did not get the best care. Luckily, it was not done in National Hospital. We were even the ones that found the problem. But that shows you how important immunohistochemistry is. And guess what? National Hospital also is internationally certified for immunohistochemistry. We are pathology lab when it comes to immunohistochemistry for breast is standard. So nobody has any business taking their sample outside immunohistochemistry. Genetic counseling. You've heard about how they say it's like they have cancer in their family. There are certain people who should get genetic counseling. And I urge you, you bring your patients, relatives, you bring your loved ones, ask the oncologist. Ask them. I always, when you have an informed patient, they're the easiest to deal with. Because when they're informed, you don't have to be repeating yourself or going back and forth. You're speaking the same language. And the outcome you can take is always better. Let me not waste too much time. I really want to get to that And what I'm hoping here is hours of work of the department. We sat together and we came up with this document where we were hoping that every breast cancer patient in National Hospital will have this document filled out for them. Based on this document, I'll be able to comfortably tell you, we always talk about late presentation, but if you ask us, what percentage of the patients are late? We don't know. What percentage of them present in stage 1? We don't know. We don't know. And you see, it's only when you know these things that I can lobby and get clinical trials and get medications for free for our patients. But if I don't have your support on making sure this document, or this type of document, doesn't have to be this exact one, becomes a reality, we will just be running around in circles. I was so upset the other day. Just that their oncology department is this tiny. It's already getting free medications, oncology drugs that my patients are paying 1 million naira for. They're getting it for free because they have their statistics. They are able to, maybe because they're university teaching hospital, I don't know, but we are better. And I know we work so damn hard in this place. So this document, I'm hoping at the end of this we'll agree and put it on health in a box. The first thing I expect is, of course, we all know the first biodata. Everybody in this room does biodata. But what is peculiar to the breast cancer patients is the presenting complaint. It's what they do. Presenting complaints, we expect that to be well documented. We've given space for it to be even 4 spaces. So whether it's a breast lump, bloody discharge, milky discharge, itchy breast, whatever, you document it. Then the next one is the breast lump, which we all know. The breast lump, which breast, left or right? Going through this document with a patient will take you less than 15 minutes. Vis-a-vis when the doctor is trying to clear and you spend 35 minutes, and at the end of the day you don't have a complete document. So we're looking left or right, location within the breast, where, how long have they had this problem, is it painful, change in size. These are all classical things that we learned as medical students. But I tell you, when you're trying to clear that patient, you will forget some of these things. But there's nothing like checklist. Like you know how in navigation, airplane, before you take off, check. It ensures accuracy and efficiency. So we have now converted this into a checklist form. Scroll up, I think the check, then okay, skin changes. Type of skin change, just check. Is there breast ulceration? If yes, for how long? Location, discharge, color, presence of bleeding, pain. Then you go on. Nipple areola changes. Scroll up. Then we come to swelling in the armpits, yes or no. You know when people talk about breast cancer, we just focus on the breast itself. But the single most important finding in breast cancer is the axilla. It's actually what determines the outcome in that patient. So we must not forget the axilla, and that's what we put it there. The axilla is the armpit for the non-doctors. It's the axilla, the underarm. So, is there swelling there, yes or no? Then we go further down. Spinal cord compression. Now we're going to features suggestive of spread. The reason why I'm going into all this, even though you're not all doctors, believe you me, next month, October, people will ask you about breast cancer. They're going to ask you, and I want you to know exactly what to tell them. We've had scenarios where somebody collected their lab result from pathology, and the secretary told them that everything is fine because it's triple negative. Triple negative is a type of breast cancer, it's very aggressive. But I know someone that it happened to. And the woman went home and celebrated. She had attended this type of lecture, it wouldn't have happened. Because by the time you leave this room, you'll be very clear on what is not. Risk factors, of course, we all know we don't know what causes breast cancer. But we've studied things, in the past, and we know certain things that it is more common in people with those characteristics. They are called risk factors. So, in the history, we want to, like I said, check. We're asking, do you have previous history to radiation, breast trauma? I know some patients think, no, it's not breast cancer, somebody hits me. So in her mind, there's nothing you're going to tell her. She knows she was hit on the breast. There's nothing. You'll be surprised that maybe the lump was hiding before they hit her, and she, misunderstood or just got sidetracked. And there was a word physiotherapist used. What was it? There was a word you used, like a smoke screen. Thank you. It's masquerading the actual breast cancer. So then we talk about prior cancer. Have you ever had someone that you thought was close to and they had cancer in the past? It happens. They will just not remember to mention it. So doctors or whoever on health levels, we want it to be a question we want to be intentional about this thinking. Go to her hormonal history, that's her O&G history, that's what, Then before we go there, was a place that talk about family cancer. Father, mother, auntie, sisters, brothers, very important. We want to get out that information. So that at some point, I can now push and say the genetic testing should be part of NHIA. They should pay for it. For any patient who has an obvious reason for us to believe it may be a familial cancer, NHIA should pay for it. But I can't push for things like that because we don't know. But guess what? If we run this through health in a box and everybody takes it seriously, we will not just empower ourselves, we will make sure NHA oncology, NHA cancer care is top notch. So that's why I've come to this house to come and push my agenda through the National Assembly. Okay, so then we go into, she breastfeed, she did was exclusive. I know most women don't exclusively breastfeed. We need to document all those things. Fertility history, it's a long form, but as I said, we timed it. It takes less than 15 minutes. Have this on health in a box, patient wants to breast pump, click, and at the end you have complete information on this patient. With regards to the diagnosis, the treatment, as well as the prognosis, it's all involved it's all contained here. It's full of history of care. So, the pathologist, this is really their territory, pathology and surgery, the type of biopsy. I still find sometimes they want to do a biopsy and they still take a big chunk of the lump. Nobody is doing that anymore. That is not right. What you now need to do is just take a little piece, like a syringe in a true cut, just take a little tiny piece of it. It looks like a thread, that's the amount you need. One of those days when they will put a big thing that they'll be showing you in a container. No. There's life after cancer, there's life after breast cancer, so we have to, do the right thing. So the type of biopsy that was done, was it incisional? I'm still putting that because I know not all, and I found that 70% of our patients come from outside. I was really shocked that when we looked at the data in the department, 70% of the patients are from outside, they're not from within. So that's why I had to put that. Within here, we're not doing incision anymore, we're doing the right thing. Dr. Manager is top of his game. So he's doing the true, because the whole surgery department is doing the right thing when that is concerned. With the results of the biopsy, immunohistochemistry, Dr. Jibril will send us an immunohistochemistry. And the type of surgery, was the whole breast they removed? Was it part of the breast they removed? We need to know. They go into the armpits, what they removed, extremely important. Extremely important. Then we talk about the chemotherapy. Has the patient had chemotherapy before? Now, at this point, let me mention, there are certain drugs that there's a lifetime dose that you're allowed to receive. So when they refer a patient numbers from one hospital to another hospital, and they want to lie. Have you had chemo before? No. Are you sure? No. They're saying that because they think maybe if they tell you the truth, you might not want to take them. They don't realize that they're doing themselves great harm. There's a lifetime dose of certain drugs, so it's very important. Especially when, and the reason why I'm so happy, because guess what? Who is the first person that the patients meet? The nurses. Who's the person they confide in? The nurses. Who does most of the counseling? The nurses. And they are here today. My oncology nurses are here. These are things that they know. But we still know that 70% of our patients come from outside, meaning that they either came through GOPD or wherever. So it's important. We all know and we tell our patients the importance of these things. They must be truthful. The most that will happen that is everybody's face will be somehow, but after that we'll move on. They must be truthful. What treatments have you had before? How much chemotherapy? What chemotherapy did you give? Have you had radiotherapy before? Where? Because once you tell us where you had it, we can get the information for you. It's extremely important that we have all this information. So we went on to constitutional symptoms, ENT, cardio. These are all basically the clicking of the patient. But if we're able to standardize it in national hospital, we will get beautiful picture that allows us to really push the chances of cure for every woman with breast cancer. As long as she doesn't come here with a stage 4. If she comes with anything less than a stage 4 and we follow this, we'll have every chance, just like she was abroad, be able to push her into being cured. And for me, that's a very important thing. This woman, we're just getting her history. She has diabetes, hypertension, asthma, what drugs has she been on, allergies, all those things. Social history, we're looking for all the relevant things, smoking, cigarette history, all those things that will be relevant to the prognosis and all that. Then there's something that has been joined to the care stop. It's called the distress scale thermometer. This is something that in oncology is very important. In other departments, you might afford not to take it so seriously, but in oncology, this can make the difference between the patient running away or the patient coming back to take their treatment. You have a very anxious woman, she's 38 years old, newly married, you are telling her that you want to remove her breast and she cannot have children, or she's 36, just met this guy she's dating, we want to take out her breast. Oncology has that way of getting to you. But if you are told the right things in the right manner, which reminds me, there's a course going on right now online, maybe we'll share it at some point, on palliative care. Yesterday they discussed how to break barriers, communication. We're all healthcare providers here. Not everybody knows how to talk to patients. And it's something that I will urge management to start teaching us how to communicate in the hospital. It's very important. Talking to you, at that time you might not mean it, but the impact of that on that patient might be what stops her from coming back to national hospital. End up in some other hospital where they will mess her up. Meanwhile, guess what? You had the ability to help her, but because you were nasty, maybe because for another reason, may not have anything to do with her, but you were nasty. So by the time we make one conscious of the way we communicate with these patients, if you're really irritable and you want to snap, talk to yourself quickly. Say, madam, can you just give me a few minutes? It's not a good time. Can I just do this? Then you can take a deep breath. By the time you come back, you are able to talk to her properly. You are able to direct her to somebody who is more patient at that time. Or be able to have a system that she's officially counseled and given the right information. Because I tell you, there's so much bad information out there, so much of it. I met a patient that had Jasmine told her that if they touch the breast lump, she would die. She ended up not doing a biopsy. Wealthy. Money is what they say if you can buy life. What kind of wealth is for her? They can. The next thing, the disease continue, spread to the brain. They wanted to help her to go to the US to go and do one proton therapy that cost $65,000. They had many big plans. When they called me and said, there's no biopsy. Because I cannot write that biopsy. But she refused. She ended up dying without a biopsy because she was told that if they touch it with a knife. So that is the level of misconceptions that are out there. This is not an awareness lecture, this is an empowerment lecture. Okay, what else do we have? So we have we put out so many things, but as I said, 15 minutes you'll be done. You'll be done. We won't talk you can see what we have there in red, but that doesn't, we're not going to put that on health in a box. That will come later. Alright, go on. This performance status is another very important thing. Stop. Performance status. One thing that we find in oncology is a member of staff has a loved one. They've gone to another hospital and they were told there's nothing we can do for this patient. And they bring it to a national hospital. Because they're close to you, they say to you, doctor, just try. Just try. Let's just give chemo, just try. This is what guides us, the performance status. That somebody is walking around doesn't mean they are fit. And if their performance status is not good enough for that treatment, then please respect the doctor's decision when they say, I'm sorry, there's nothing we can do. This patient is not fit for this treatment. It's not about the money, it's not about the availability, it's not about the want, the intention. It's about whether it will benefit the patient. So, after performance status, we do we're asking us to do all these things. Now the scar. I feel bad because the surgeons in the room know this already. So I feel like I'm preaching to the choir, talking about the scar, the relevance of the scar. So I don't think I'm even going to bother. I know for sure that they know the implications of the scar to our radiotherapy and all that. So I don't think it's really necessary. If I had surgeons from outside, maybe I would have, but I'm very confident that we are fine. The essence of this form, like as I said, is for it to be on health in a box, and for every woman who has breast cancer to go through this form. Now, let's go back to management of breast cancer, according to the guidelines, having done this for the patient. Apparently, breast cancer is not one disease, by the way. Breast cancer is many different types of diseases, but they are grouped together and called breast cancer. And each one has its own characteristics. Like I always say, if a man is chasing a Yoruba girl, he knows that a radio will speak to her. But if he's chasing a Igbo girl, he knows that he can use what people call it, abacha. It's the same thing with breast cancer. If you know the subtype, I always tell when you're going to war, if I know the capability of my enemy, I know how to prepare. It's the same thing with cancer. If you know the characteristics, the basic molecular characteristics, I will know how to handle it. I will know the special type of medication to give. I will know how to sequence the treatment. There's some types of breast cancer that will tell you, don't go to surgery. Let's do chemotherapy first. And the other one I will say, do surgery first. It all has to do with the subtype. It's extremely important. When you bring your loved ones, when you are talking, because some of you are going to do health talk next month, your church, in the market, wherever, let them know. You work in a place that has a cancer center, so you should be the ones that are giving the right information. You can talk about all the grading. Like I said, I'm not going to bore you with all this. I just want us to take home the relevance of this. So what have I said? Know the subtype. Know the stage. Next slide. I want to show you the reason why you want to stage properly. This table, no one used to go for exams in those days. We used to cram this table. But I thank God for today. I don't have to do it by hand. I have the app on my phone. So when you come like this, I just put the thing inside my phone. Tell me what stage. This table determines the outcome for the patient. It is tied to the 5-year survival. So if a patient, and of course the higher the stage, the worse off and more aggressive the disease is. The earlier the stage, the better the chances of cure, and the earlier the disease is. So it's extremely important that every patient, and I'm so happy already in Health in a Box, line after histology, there's a stage there for stage. TNM stroke stage, I urge all of us to take it seriously. Physiotherapy, when the consult comes to oncology and the stage is not there, call us out. Call us out on it. Even if you're not looking, we wrote a consult and you didn't put the stage, call us out. It's something that it should become a normal lingo. The proper TNM stage class, put it there, because that determines so many things. Another very important document that I found and I thought I would share with the House, it was written on the 29th of November 2021 from the Federal Ministry of Health. It was from the Permanent Secretary, from the National Cancer.Desk, I think, to all Chief Executive Officers, federal teaching institutions. The subject was setting up of multidisciplinary tumor boards in cancer treatment centers. What does this mean? This means that cancer care by government, now this is the policy, must be MDT. It's now must. It's no more. You know when you first started in National Hospital, it used to be like when the doctor likes you and he wants to do you well, he will organize and get his friends to come together and then they sit down and discuss your case. Then after some time it became like if you're a member of staff, they will try and organize. Now it has become the law. It is the law. Every breast cancer, every cancer case should be discussed as an MDT. But guess what? I told you just now that every Thursday we see nothing less than 30 brand new patients every week. We have a breast MDT meeting on Tuesdays. So, back to the modalities of treatment. What makes National Hospital special? Why are we different from global? They are teaching hospital, they are this, that. It's radiotherapy. We are proud to say that we have the radiotherapy department. And that department, even though you'll be hearing things like, hey, machine is bad, machine is bad, believe you me, what we are doing in that place is not funny. It is not, it's not funny. But guess what, it just got better. The new management has taken it upon themselves to put things in place to make sure our machines don't break down. So, we have radiotherapy as one of the treatments, which is just giving radiation to the body to kill with the aim of killing cells. That's what it is. Chemotherapy, giving chemical inside the vein with the aim of killing cells. Immunotherapy, using the patient's immune system to attack the cancer cells. They're basically simple things. How do we sequence these treatments? What guides us? What informs us? Is it just, I just look at the patient face and say, start with chemo first? No. There are certain guidelines. Medicine was not, it's an art. But the guidelines are there. You don't need to cram anything, you don't need to be too intelligent. Just your adjuvant. Like I said, I really don't feel so comfortable saying some of these things here, but because we have other people in the house, I will. My surgeons know this. But surgeons outside are still doing it. They will say they are doing toilet mastectomy. The breast was fungated or smelling, they just carry her to surgery. It's not always the best decision for her. Now, who are those that we should give chemotherapy before surgery? And I want to explain one concept to you so that you understand why it's so important. Now, forget that you are doctors. Let's just talk like we're in the market. You have a breast cancer. This side, left side. She has left breast cancer. And you want to give, you allow her to cut the breast off. Then you now say, because there may be some small ones left in the body, let's give her chemotherapy. And then you give the chemotherapy, and then you give the radiotherapy. Is there any way of knowing if that chemotherapy would have worked for the cancer? There's no way of knowing because you've removed the cancer anyway. Vis-a-vis, the breast cancer is still on the woman. You give her the chemotherapy, and you send her for surgery after she has finished her chemo. Now you have the raw data of the killed cancer or weakened cancer. So when Dr. Jibril looks at it, he has two ways of reporting. Dr. Shagaya, there was no response. Cancer still is there. Or, oh fantastic, you have complete pathological response. No single cancer cell was found. Or, there is evidence of partial response. It responded, but not fully. When they do that, you now know what next to do as an oncologist. If it's a complete pathological response, then I know, wow, I've done well, chemo was good, I can go on to do other things. But if it was harsher or no response, what does it mean? I'm going back to the drawing board. I'm going back, we need to give chemo again, another time. But for that woman that just rushed and did the surgery and took chemo when the explorer has been removed, how do you know? You know how you know? When 2 years down the line or 3 years down the line, she comes back with disease has spread. Because you do not have the opportunity to be able to know with the cancer in the body to check. Many years ago, everybody thought of neoadjuvant as just for squeezing the breast so that they can do, instead of doing mastectomy, we're going to do breast conservative surgery. That's the whole part of the breast and all that. Things have changed. This concept I've just described to you is the way to go. Aiming for complete pathological cure. That is what the oncologist aims for. Everything I do when I'm seeing a patient, because I'm trying to aim, because when you have complete pathological cure, the patient being cured is almost a given. Vis-a-vis when the disease is still there. What does that mean? You know this patient is going to come back. So the list there are the candidates for neoadjuvant. Those patients who have the HER2 overexpressed, pathologist surgeons, I know we're all happy. People in the house will be wondering what I'm about. A very large, so you have a very large tumor vis-a-vis a very small breast. That's another candidate. Inflammatory breast, locally advanced, and patients who for some reason you have to postpone surgery. Maybe doctor strike or Joesu strike. You might consider giving chemotherapy while you are waiting. The only people that can, off my head, are very clear. They sign the consent form at the surgeons. And the reason why the surgeons are able to get it is because the nurses make sure they signed before they allow that patient go into theatre. But every other department, please, any other departments represented, do you routinely sign your consent forms?
Yes.
What department? IVF. Because they will sue you. If you don't sign and you say, hey, they took my money. Nuclear medicine, by the psychedelic department. It's a good thing. Oncology. I can tell you how many times we've had this discussion in my department. We will discuss, our intentions are pure. That's one thing I can tell you, but do we follow through? And that's why, like I said, I brought this document to the National Assembly to enforce it. Because let me tell you something, litigation has come. Things have changed. Gone are those days when they say, because of God, just forgive the doctor. Or because it's from your village, please. Things have changed. When someone has spent 25 million on their treatment, they now whisper to them that there's one place that you can pass and sue National Hospital because did you sign? Believe you me, it's going to come to stay. So this is another form that we're also pushing. So when we do our clerking, before we do radiotherapy, we're pushing for this form to be signed. In fact, it's one of the layers we're planning to put that if they've not signed the consent, treatment cannot progress. The reason why I need you to understand this form is that so that you don't ask us to do between simulation and treatment in 12 hours. The actual process, even in the best of countries, it takes sometimes 2 weeks. But I tell you, I know some of you here, I can see 1 or 2 people have said that I know their patients got treatment within 3 days. We're trying to make that part of the hospital an ideal place that you will all be confident, God forbid, if you have need of our services. That is our aim. Because like someone said to me yesterday, they said, when you retire, next time, that's the name. When you retire is when better disease used to come. And if you allow this place to be run down, believe you me, what is 600,000 naira here or 800,000 naira before NHIS? In Lagos is 3.5 million. So we own this place. Let us do everything in our power to make sure that oncology national hospital remains and give us the support. We're a department that cannot stand alone. I need everybody in the MDT to make that patient come out right. So I'm urging all of us to please, I'm rounding up, next slide, to please give us that support That's our clerking sheet that we have worked on, our consents, all those things. Please, so that in 1 year's time I can stand here and give you the local data, and not just, people always present challenges. I want to present the successes of the National Hospital. Thank you.
So how can we differentiate between stage 2 and stage 3?
Do you get to see more of the stage 3 and stage 4 patients, or more of stage 1 and 2?
At what point do you invite physiotherapy, considering the various musculoskeletal issues and lymphatic issues we have, and then post-operatively too? So at what point do you call us?
Are there measures, are there preventive measures, standard preventive measures? Because I'm kind of a layman in this area. So you didn't talk about the risk factors, and I think that many people don't know. So are there standard preventive measures that people should know, that you can educate people on, and that would make things better?
Expatiate mammogram, the category of the BRAT or B-rate.
Genetic counseling, clinical psychologists, they are all part of the MDT. Now, when you ask about the stages that patients presented early or late, I trained here. So I'll tell you, when I first started, it was the norm to have that huge fungating mass. They're beginning to come not as frequent.
These days, we've been involved in a lot of multi-center studies. We are currently working with Argo. We work with Africans. The great majority of our patients present 3 and 4. But the early stages are rising. Even for stage 3 cases that have been downstaged following neoadjuvant therapy will stand a chance. So we are hoping that we are able to do, we talked about mastoplasty, okay, and then also outside reconstruction as the case may be. To answer the question of the geneticist, there's actually an ongoing course via Argo on genetic counseling and management of hereditary breast cancer. Collaborations we have to be able to do BRCA gene assessment, courtesy of our collaborations across the board.
She had never seen the physiotherapist before surgery, so she can start doing the exercises before. And if you don't know the characteristics, or if you don't know the capability of your enemy, you can't go to war properly. So when I have that breast cancer patient, I want to know where it has spread to. There are certain times I have to go to the famous, but they own the ultimate test, which is the PET-CT. Standard preventive measures. Remember I said I don't know what causes breast cancer. However, I know certain behaviors that when they studied, they found breast cancer to be common in those group of people. One, if you are a female, you have a stronger chance than a male. Males have breast cancer if you are a female. Your lifestyle. Lifestyle, what do I mean by lifestyle? It's not about drinking and smoking, excessive drinking and smoking, and associated with breast cancer. Then, exposure to uninterrupted hormones have been insinuated, not exclusively breastfeeding. Early menarche, late menopause. What do I mean? A longer period when the breasts are going through the cycle of being exposed. Reverend sisters, nulliparity, because they don't ever get to breastfeed. Not exclusively breastfeeding. Obesity, size, lack of exercise. Also the very sedentary lifestyle, most fat. And your first pregnancy after 35. Young, I'll say I want to be fully settled if I have my first child. Too quick. Anyway, so those are the common risk factors. You know the risk factors you avoid. BRAT is being a radiological way of staging breast cancer.
BRAT actually is just a classification of breast imaging for ultrasound, mammogram, MRI. Right? So just to classify patients and what to do. So usually from 0 to 6. Okay, 0 usually they will say there is no assessment. Usually patients are recalled for additional examination may be required. 1 is usually regarded as negative. Okay, what do they usually do? The possibility and likelihood of cancer in those patients is usually 0. Okay, because 1 and 2, 1 is benign, or 2 and 3 rather. 2 is benign. Okay? Routine screening, likelihood of cancer is usually 0, just like negative. Class 3 is considered probably benign. Okay? Usually 0, but there's a likelihood of cancer is about close to 2 or 2%. Okay? And such patients are how you manage them is the early follow-up imaging. Usually less 6 months or so you can repeat this scan. Then there's 3 or 4 is usually suspicious malignancy, and so that one is divided into low, moderate, and high. So high is usually almost more than between 50 and 5%. Whereas 5 is greater than 90%, and 5% chances that it's cancer. But how do you manage this tissue diagnosis? So 4 and 5 is tissue diagnosis you require to confirm your diagnosis. So those are the variants, so it's essentially just for nomenclature in radiology and also for management of patients. Blood 6 is usually a proven tissue diagnosis, or a proven one, and excision, of course, removal is managed. So I think that's just about that.